morning. So we are waiting for a couple of minutes, our colleagues, and we will start soon. We will really appreciate, if we can stick with the time because we already on behind. And the next session will be also late. It's very important for us, to be on time. So I was given assignment for today, for this time, to be moderator, facilitator to the session. And I am very happy to do this. My name is Mohanad Insoor. I am from EMPHNET. And as we yesterday mentioned that the theme of the conference, public health challenges and opportunities. And one of the major challenges in the region is the public health and emergency situation that we are witness in our region. No doubt that our region, one of the most unstable regions at the global level in terms of emergency. So in the past 2 decades, the region witnessed many of emergency situations like floods, like droughts, like wars, civilian instability, earthquakes. In addition, also I like to highlight the role of new re-emerging diseases in this area. We have very interesting speakers in this session. I would like to welcome our guest speaker, Dr. Nada Alward, coordinator of the emergency support team from Syria crisis, WHO EMRO. Most welcome, Dr. Nada. We have Farah Hussein, Emergency Response Recovery Brand, CDC Atlanta. And we have Ms. Rawan Araj from EMPHNET. She is going to present overview of EMPHNET Rapid Response Initiatives. And we have very precious colleague, Dr. Abdul Wahid Srouri, who came in from Yemen. So Dr. Abdul Wahid Srouri, by the end of, he will present the current situation, the emergency situation in Yemen, and how much we were effective to respond to current, emergency situation in Yemen. So thank you all. And we would like to start with Dr. Nada Alward. Thank you.
Good morning, ladies and gentlemen. Today's presentation is going to be about the WHO response to emergencies. Is there a way to? Okay, thank you. So the 21st century had witnessed a number of changes that had affected people's health, lives, and livelihoods. There has been a number of armed conflicts, terrorist attacks. We are today witnessing terrorism affecting the lives and health, and also the livelihoods of many people. There has been mega disasters. We all remember the 2004 tsunami, the Indian Ocean tsunami. Climate change and its effects. There has been food and fuel crises in several places in the world. And then there has been the famous financial crisis of 2008. The world population had grown bigger, much more urbanized than before. Life expectancy is increasing and the population is getting older. Poverty is increasing and 70% of the world's poor live in middle-income countries. And the differences, the discrepancies between the wealthy people and the poor people is getting bigger by the day. Social injustice is still a problem. Hunger is still a problem. The changes in lifestyle had led to the increasing prevalence of so many of the non-communicable diseases. Social media had played its role in distributing health rumors, but also in distributing the good word about health. So distributing also health information. The world is witnessing antimicrobial resistance, leading to many conditions that were treatable with the simple first-line antibiotics being now resistant to these antibiotics. And the progress in the development of new generations of antibiotics is not actually going hand in hand with this resistance. And of course, we have witnessed viral diseases, the Ebola and the H1N1, and now we have the MERS-CoV virus, and we have the SARS. Globally, and in the decade of 2001 to 2010, per year, more than 700 natural and technological emergencies on average were reported, affecting an average of 270 million people and causing more than 130,000 deaths per year. 1/4 of these emergencies and more than 44% of the deaths related to them happened in less developed countries with limited emergency preparedness and response capacities. On the other hand, there has been many conflicts, and there has been very high morbidity and mortality associated with these conflicts. The World Bank figures indicate that more than 1.5 billion people, that's about 1/4 of the world's population, live in countries affected by conflict. They suffer consequences of societal disruption, infectious diseases, acute malnutrition, trauma, and complications from chronic diseases. There has been an increased risk to public health due to globalization and international travel and trade. And yesterday, of the conference, we've all seen the very beautiful slide displayed by CDC colleague on the air traffic, global air traffic. It's scary how one case of one infectious disease can travel the world and start an outbreak in a country that has never known that disease before. These conditions can be transmitted by people, conditions such as SARS, influenza, polio, Ebola, or by goods, food, and animals, such as zoonotic diseases, by vectors, such as dengue and plague and yellow fever, or the environment, such as radionuclear releases, chemical spills, and other contaminants. Normally and usually, and as always seen, the poorest and the most vulnerable people suffer disproportionately from these emergencies, and the resulting economic losses count to more than $100 billion per year. Now, the WHO has a mandate since its establishment back in 1948, and its objective is that of attainment by all people in this world of the highest possible level of health. You will say that we haven't achieved this goal. We haven't, no, but we're working very hardly towards it. WHO supports its member states to prepare for, respond to, and recover from emergencies that have public health consequences. And WHO is committed to its health leadership role in emergency response through the Article 2D of its constitution, and also through many World Health Assembly resolutions and regional committee resolutions that we can refer to and find posted on the internet. WHO has obligations to many bodies, to the Interagency Standing Committee as a health cluster lead agency, and also to the International Health Regulations 2005, and to other international bodies and agreements related to emergency response. Due to this, and due to the transformative agenda of the Interagency Standing Committee back in 2012-13, WHO revised and reviewed its role in emergencies. And the first edition of the Emergency Response Framework was published, showing the WHO core commitments in emergencies. I must say that this ERF, as we call it, Emergency Response Framework, is currently being reviewed for a second edition, with many changes adapting to the WHO soon-to-come reform. In emergencies, WHO supports member states, ministries of health, and local health authorities to lead a coordinated health sector response together with national and international community. And WHO will always deliver and be accountable for the following. First, to develop an evidence-based health sector response strategy, plan, and appeal. So whenever there is an emergency, WHO supports, WHO doesn't lead on this. We support the Ministry of Health, the de facto health authorities, whoever is the lead at the national level, to prepare the response plan and strategy. And this has to be based on evidence. And those colleagues who were in the session on emergency yesterday remember that we have spoken a lot about assessments and about indicators and about information. So these plans and appeals need to be based on such solid basis. The other commitment is to ensure that adapted disease surveillance, early warning, and response systems are in place, even before an emergency. But when an emergency hits, this is the way to detect these outbreaks early and to be able to respond to them timely and efficiently. Also committed to provide up-to-date information on the health situation and health sector performance, promote and monitor the application of standards and best practices, and provide relevant technical expertise to affected member states and all relevant stakeholders. Now, under the Emergency Response Framework 2013, WHO has 4 critical functions in emergency response. The first is that of the leadership and coordination of the health sector or the cluster, depending on the context, in support of the national and local health authorities. The second is the coordination and collection, analysis and dissemination and communication of essential information on health risks, needs, health sector response, gaps, and performance. And you can see from the pictures here that WHO uses many of these products, such as the initial rapid assessment tool, the assessment reports, the donor updates, the E1 bulletins, and of course the HERAMS. HERAMS is a tool that we use to assess, it's short for Health Resource Availability and Mapping, to assess the capacity of the health system to be able to respond to emergencies.
So we can, 2 minutes maybe?
2 minutes is
1
quite
minute,
enough.
yes.
Thank you very much. The fourth critical function is in emergency response is to provide technical assistance appropriate to the health needs of the emergency. And I will not go through this, but one of these is to provide the guidelines, the best practices, and you can see the guidelines for mental health and for disease early warning system. The fourth is to support core services, that is logistics, human resources, procurement, supply management, administration, finance, and of course, resource mobilization. As I mentioned, WHO is consulting with its global partners to reform its work in emergencies. And in this process of consultation, which should be finalized by the end of this year, this is a commitment that was made by the Director General during the World Health Assembly this past May, has five main elements. The first is creating a unified WHO program for health emergencies accountable to the Director General, establishing clear performance metrics for the program and build on partnerships with other responders, establish a global health emergency workforce, and strengthening a core and surge capacity of trained emergency response staff. So that is the organization being ready to respond. Developing a new business process to facilitate a rapid and effective response, and to create a stable fund, that is the contingency fund, to be able to immediately respond to emergencies of an amount of $100 million. That would be the money ready for us to respond. Thank you. Thank you very much.
Thank you, Dr. Nada. Next speaker, Ms. Farah Hussein, and she's going to talk about the Global Rapid Response Team Initiative from CDC side. Just to, each speaker will have 7 to 8 minutes to present, and then we will open the discussion, we will open the floor for discussion. Thank you. Appreciate sticking with the time we have.
Thank you for having me. I'm going to talk about CDC's initiative on standing up the Global Rapid Response Team. And it's to enhance the agency's emergency response capacity, as well as to strengthen the global emergency workforce. This is a brand new concept for CDC, where it's unfolding as we speak, and this is actually the first time that we've ever shared it externally. So just a little bit of a background. We're familiar with the IHR mandate that was revised in 2005, and basically the mandate is for countries to be able and ready to respond to public health emergencies of international concern. And if those of you that were at the opening ceremony last night heard about the Global Health Security Agenda. That's okay, I can hold it. Yeah, it's not fine. It's fine. The Global Health Security Agenda, it's to prevent, detect, and respond to cross-border threats as an international priority, similar to the IHR mandate. And that was launched in early 2014. At the end of 2014, they found that only 33% of countries were IHR compliant. And then Ebola happened, and it really exposed the weaknesses of the international community to respond to unprecedented emergencies, which got everyone's wheels turning, and it really kick-started the initiative to be able to respond better globally. So around middle of May 2015, CDC started its Global Rapid Response Team initiative. And around the same time, the World Health Assembly gave the green light for WHO for its reform of its emergency response programs, which Dr. Nada had talked about as well. So what's the role of the what is going to be the role of the Global Rapid Response Teams? It's to serve as a deployable asset to support global public health concerns. Also to enhance our capacity as well as the international capacity to respond. And that's by providing support to CDC country offices, to the Ministries of Health, and to international partners. And this includes building the capacity of both the EIS program as well as the FETP programs, and supporting international health partners to train the field, local, national rapid response teams. So what are the main objectives of the global RRT? It's going to be to respond immediately to health threats, and that's not new for CDC, but hopefully they'll be able to do it better and faster. Provide long-term staffing for emergency responses, and this is really a consequence of Ebola. Many of us were deployed on 1-month rotations, and I think for us it was a long time, but there was a loss of continuity, and that was disruptive to the response efforts. We build relationships with partners and the ministry, and then there would be a new person to take over that role and have to start all over again. And it was also a loss of institutional memory and experience. So hopefully this will help to solve that by having more of a sustained presence in a continued emergency. Also to deploy field-based logistics, communications, management, and operation to support the emergency. So really tapping into other skill sets that are very much needed to support an emergency. To provide additional staffing for backfilling critical overseas positions. So this is really for CDC country offices as well as our UN partners when they have specific staffing needs. To serve as CDC's counterpart to the Office of U.S. Foreign Disaster Assistance, or OFDA, which coordinates the U.S. government's response to emergencies, and to assist partners in trying to achieve IHR compliance. So the global RRT will hopefully be able to support the following sectors: capacity building, epidemiology, logistics, health promotion, lab, long-term staffing, partnership and coordination, rapid assessments, risk communication, and surveillance. So the framework for the global RRT is a tiered structure. Tier 1 will be the core team, and they're going to be based in Atlanta as well as overseas, and they'll be the first to deploy. Tier 2 is what already exists, and that's the current staff of the Emergency Response and Recovery Branch that already work in international emergencies. And then Tier 3 is the surge. It's our surge capacity. It will be comprised of an additional staff of about 50 people who are on call at any given time. And they'll make up the additional skill sets. So this is where we are now. As I said, this is really unfolding as we speak. It was started in May, and we've completed the recruitment and hiring of our Atlanta-based staff, and we are in the process of hiring our overseas staff now. We've started some of the training for the staff, primarily on all the requirements that the U.S. government needs to deploy internationally. And we've developed the curriculum for the technical training for EIS and for FETP. And we will roll it out for EIS during their fall course, which is in December. And then for FETP will be early next year. And we're in discussion with the CDC FETP folks on where and when and how and all that. So it's to come. And you can find more information on our website. This was just posted this week, so it'll be changing, but please refer to it for progress. Thank you.
Thank you, Ms. Farah. So, next speaker, Mr. Rawan.
everyone. Thank you for coming again today. So since today we're going to be talking about public health and emergency, it's a good time to talk about the EMPHNET initiative in facing and building regional capacity to face global health threats. First, I'll give you an outline of the steps taken by EMPHNET resulting from its extensive experience in the regional countries in Eastern Mediterranean region and the framework it's working on. The initiative started in 2012 when EMPHNET identified the need based on the global health threats we're facing and established a framework. And this is when it's piloted the first rapid response team. In 2013, it started improving on these rapid response teams' training and started further trainings that are more focused on international health regulations and its core capacities. These improved trainings were also distinguished by the fact that they used the training of trainers methodology, where national responders that were trained, they went back to their home countries and starting training provincial responders as well. In 2014, EMPHNET also started working with a national effort. They started working at the Emergency Operations Center that started at the Ministry of Health, and they started activating the Incident Command System and the standard operating procedures to collaborate all the efforts and respond in a timely manner. In 2015, the work was at a much larger scale, and we had different activities also emphasizing the need of rapid response teams, and we enhanced a lot of the preparedness, and we increased the linkages between the different countries and the health services provided at the different countries. We also supported more IHR trainings to ensure the implementation in a timely manner. Of course, these efforts are ongoing, and we have future plans that we keep revising depending on the needs. So this was an overview. Of course, these steps were taken based on evidence from the field. And again, they are continuously being revised depending on the need in the region. To be more specific about the activities that we've taken, because of course each of these steps entailed a lot of actions. In 2012, again, we recognized the needs and the global health threats. And as Dr. Ijaz nicely showed us yesterday, any threat anywhere is a threat everywhere. And EMPHNET understood this very well. And based on that, started its own strategy of rapid response. The project that it had, it was a multi-stage, and we're going to show that at the end of the presentation. It's more than one step, and again, it adapted depending on the situation. It's piloted the rapid response teams again in 2012, but that got improved year by year. The first rapid response teams training resulted in deployments in Sudan, Jordan, and Iraq to respond to yellow fever, measles, and cholera. In 2013, we started collaborating with more partners like WHO, CDC, and others, and we start using the training of trainers methodology to allow more people to get trained and respond to emergencies. We also piloted, along with the WHO headquarters and the regional office, the International Health Regulation for Epidemiologists that targeted epidemiologists particularly to better able to implement the international health regulations core capacities. This again resulted in national responders that were offering a series of training for provincial rapid response team responders. In 2014, we conducted further trainings based on the improvements we had and the success stories we had from previous years. And we also got involved with the orientations and workshops that are being offered for the emergency operations system to establish better national connection in Jordan. Again, this has engaged all national first responders in the country, and it activated existing standard operating procedures in the country. 2015, we had a couple other trainings besides rapid response teams. We had rapid detection, assessment, and response to outbreaks of suspicious origins. This training was the first training at the regional level that allowed rapid responders to distinguish between natural outbreaks and intentional outbreaks. We also had a specialized training targeting rapid response teams like the Ebola virus disease. This was also a special training because it was an actual simulation exercise. And of course, this was with a collaboration with WHO. We had working groups from different countries working at a hospital setting and imitating a response for an Ebola outbreak. We also had another rapid response teams training with the CDC. Actually, Sfarah was with us. And this was targeted for the humanitarian situation, humanitarian crises, like the Syrian refugee crisis. So it was more specialized training. Again, we had the international health regulation training. And we had a polio outbreak investigation and response. The aim of this workshop was to develop a roster of experts that we can depend on and deploy internationally in case of any outbreak. The results of these trainings, we actually developed the roster of experts we have named that are available to be deployed at any time. And we increased linkages between health authorities because we had participation from many different countries. This is the multi-stage project that we were talking about. So we launched it in 2012. We started individual training. At the first couple of trainings, we had around 100 trained national and regional responders. And then these individuals were put in team, and they started responding to national, regional, and international levels. These trained individuals were from countries like Afghanistan, Pakistan, Yemen, Iraq, Saudi Arabia, Egypt, Jordan, and others. And they contributed to countries that were mainly affected by the Syrian crises, and internationally by our partnership with Guam, because we are a part of the steering committee. We had people sent to Philippines after the Typhoon Yolanda, and to West Africa after the Ebola outbreaks. For 2016, again, we plan to revise our strategy, make it more adaptable, but we're planning to focus more on the ministries of health as well as the individuals. So we'll have more building capacity trainings for the ministries of health as well as for the epidemiologists in the region. We'll continue to contribute in responding to global health threats because this is, again, it's part of the global health agenda, part of prevention. So actually, we have 2 projects coming up in West Africa and Ukraine in that regards. So this is our underlying structure, framework we're working on now. Again, it's based on evidence from the field. I will continue to refine it to make it more effective. This was just like a quick brief overview, but we can have more questions on specific activities if you have any. Thank you for your attention.
Thank you, Rawan. Dr. Abdul Wahab can present us the current situation in Yemen.
Thank you for giving us the chance to speak about the Yemen war situation. I think I'm going just to touch some of the challenge you are facing in Yemen due to this war. To talk about the response and other things, I think it needs more time to go. As you know, that the conflict in Yemen started in 26 March 2015. This is the official date, but it has started years before this date. The country is now going on to the unfolding socioeconomic crisis. There are worrying scenarios for the case in Yemen, similar to Syria, Iraq, and Libya. Government institutions are no longer able to provide or to deliver basic services to people, including basic health care, nutrition services, water, sanitation, electricity, and many other services. Some of the aspects of the severity of the Yemen crisis, freezing of the foreign trade due to sanctions. Yemen import 90% of it is basic food, and you can expect with these sanctions what happened, trader being unable to import enough food, and drugs also unable to safely move food inside the country. This leads to severe rise in prices and increasing suffering of the poorest and most vulnerable in a country where 50% of the population are living below the poverty line. This is just a long queue for days and weeks for oil crisis, and will all impacts on the whole surfaces. Electricity is another major problem. No electricity nearly in the whole country for the last 6 months. Higher unemployment rates, many people lost their jobs. 4 out of 5 Yemenis are lacking the basic needs to survive, just save water and food, drugs, and other things. I'm going to concentrate about some of the health impacts of this. Since the inception of this war, there are a total of 5,500 Yemeni civilian killed. Of them, 1,600 or 700 children under the age of 14, 1,300 around were women, 13,000 or 40,000 nearly injured. The numbers are increasing every day, and more than 1.5 million are internally displaced. I was not surprised to told by the driver who picked me from the airport that there are many immigrants, even in Jordan, Yemeni immigrant looking for jobs and escaping from the war in Yemen. Health situations has become catastrophic all over the country. 90% of the hospitals are under threat of closure. They don't have any way to survive. Medications and medical applicants are unavailable. Total shortage of fuel and electricity, and I will elaborate on this more later on. Around 300 health facilities destroyed by this war. 50 ambulances damaged in a country with a few ambulance services. Health cadres, 30 were killed and 100 were injured. This is just an ambulance destroyed in this war. This is one of our doctors who went to the field to save life, and he lost his life. Bad stories, sorry for this. Lack of electricity also affects health facilities in terms of performing surgical operations for those people injured, need the operations. Lack of operating medical devices also affects severely renal dialysis patients, vaccination services, with big concern about losing of a lot of vaccines in the countries. ICU incubators are not working at all. Diagnostic services to diagnose injuries and these things, and storing drugs and all these problems. This is just dark night in Yemen for 6 months. This is in the capital city of Sana'a. Nothing there except few generators and the moon, if there is a moon. So imagine that you are living in such situations for a month and months. Applying the big depression inventory shows that strong correlation between power outages and level of psychological depression. This is a recent study conducted in Yemen. Children also suffer from night phobias, behavioral problems, and anxiety, crying, bedwettings, all this. I'm not speaking about the children deprivations from their rights, recreation services, but also for vaccinations and other many things. Malnutrition in a country where the malnutrition before the war is one of the highest in the world. Around 50% of the children under 5 are stunted, SAM, beyond severe acute malnutrition, beyond WHO critical levels in many areas. Millions of Yemeni children caught up in this crisis. Around, according to UNICEF, 1.3 million children are at risk of malnutrition, and more than 60% of children are suffering untreated for a SAM. This is just one photo of them. Outbreaks, we trying our best in the FTP program in Yemen to cope with this situation. There is no water, and you can expect for all waterborne diseases. There are no sanitations, and also destroyed, and there is no government to just intervene in any way with all these destructions and with this leakage going sanitation. Solid waste, also another major problems everywhere in the country. Many outbreaks are facing measles, around 1,046 to 20 cases during the last 6 months, and not surprising due to vaccine dropout and the coverage. Dengue, more than 26,000 cases and 1,000 deaths. Waterborne disease, waterborne disease is a major problem with electricity and the suspicion of refrigerators, damaged food, and all this food poisoning and other things. Outbreaks of suspicious origins are raised by many public health specialists, especially after using strong bombardment. We are trying to investigate also in the teens, but we still have here. Psychological impacts of this war. If you lost your house, lost everything, what do you expect for to recover? And if you lose your going to be amputated foot or anything, what for the future for these youth and the children. Wives who lost their husbands becomes widows in this age, and sometimes not only the husband and the child. So this is also a disastrous thing. I guess I finish with this psychological impact. Or this is 3 years old girls just every day go to weep on her father's grave, dad's grave, and just trying to put some waters. Maybe his father come back and come back to her. So please pray for Yemen, Syria, Iraq, Libya, and all other countries in the region, and for the whole world as a whole to be safe place to live in. Thank you very much.
Thank you very much for all speakers. So now we will have 20 minutes, 25 minutes if you have questions for the speakers. So please, the floor is yours.
Thank you, Dr. Mohannet. This is very nice talks. My question is for Dr. Nada. I mean, I know you have a very short time, but could you really please comment on what you're doing really as far as the points you mentioned? What you're doing really for the Syrian crisis in Jordan?
Thank you very much. This is a very good question. And it will not be answered in a minute or two, but in general, we are doing two things. The two main things. The Syria response plan has two parts. One is implemented in refugee hosting countries. And this is what we and our partners, we call it the 3RP, which stands for 3 Rs and 1 P, Regional Refugee and Resilience Plan. Through this plan, we support the Ministry of Health to be able to provide better services for refugees in the community. We don't work at the camp level. The camp is a UNHCR mandate. Our mandate is supporting the Ministry of Health and strengthening the health system to be able to provide better services across the board. And this depends on what the Ministry of Health wants. One part is as a response to refugee. The other is to the refugees. The other is strengthening the system to be able to respond to the needs of the refugees and the host communities on the long run. The other part of what we do in Jordan in particular is what we call the SRP, the Syria Response Plan. As you know, Syria today as a country is services in Syria are provided by 3 different hubs and not only by Damascus. So Damascus office provides services to areas that can be accessed by government services and some cross-line activities to other areas. And we have 2 other hubs outside Syria, but they provide services across the borders to Syrians. One of these hubs is in Jordan, and it provides cross-border services to Syrians inside Syria in terms of supplies and also building capacity and generating information. This was not done before July 2014. In July 2014, UN agencies were mandated by the Security Council Resolution 2165 to be able to to provide services cross-border. So this is what we're doing for the Syria crisis in a nutshell, because I can talk for a day about this. Thank you very much.
Shukran. Dr. Abdul Wahab, just a question. What did you mean by outbreaks of mysterious origin?
Thank you for the question. And due to using of some of this some of the bombs, people say it is maybe prohibited to use it in a war, and some speak about even just nitrogen bombing and something bombing. So it is, and we received some reports from the community about nearby area for these bombardings of deaths of the whole families suddenly after the war by 3 days, and also for sudden rash and suddenly. So we went to just to investigate this, but still this is a new area for Yemen team, and I think we couldn't prove anything due to lack of some support from lab, from physical things that to prove such outbreaks. No, not biological, but it is just a chemical, mostly chemicals. Thank you.
Recently, few reports, unofficial reports, they are talking about, for example, thallium poisoning. To use thallium, for poisoning purposes. So still thallium, yeah. And this was, thallium was used in the past, for killing rats, mouses. So this material is forbidden international, but still we have this material in the region. So it was used in some of our countries in the region before, like in Iraq and Jordan and in Morocco, thallium poisoning. So there are few still very weak evidences to use such a material or such a chemical item, for intentional outbreaks. Our concern sometimes in intentional outbreaks that they can use some chemical materials, for example, in the water, and this is in food, and this is the issue. Yes.
Yeah.
Exactly. So it's spoiling the water resources.
Yes,
So, very nice session. So I actually have a question for all the speakers. So it seems to me that there is a lot of training which has actually occurred over the years. I mean, EMPHNET has been doing a lot of training since 2012. WHO has been doing a lot of training. CDC does some or has done some very targeted training in the humanitarian assistance arena. So in terms of the impact, the true impact, I mean, there's a lot of training policies, plans, all those kind of things which have occurred. I mean, how can you actually, or any of the speakers comment, we'll probably start with WHO, in terms of the actual impact that these rapid response trainings have actually had? People who have actually been trained, how have they been actually assimilated into their own ministries of health or in their own infrastructure? And how have they actually, can you give us some examples how they've actually responded based on the rapid response trainings that WHO has done, or let's say EMPHNET has done, in terms of the impact? I'm trying to look for the public health impact. I know there's a lot of trainings. We talk about a lot of, training of the rapid response teams. Sometimes it's actually unclear to people what is a rapid response team and what is it supposed to do. I mean, of course, there's a multidisciplinary team, but, how do you train these people? But going back to my question, it's all about what is the impact, or what has the impact been? I'm sure there's impact, but are there any figures or any examples that you can share with the audience? That would be great. Thank you very much.
We all know that impact is not a very easy thing to measure, especially when we are talking about training, because in addition to the training itself, we need to follow up after that training with on-the-job training and with performance indicators. And because WHO is not the only player in this area, because we train Ministry of Health and maybe other partners' staff, we don't have the arm, if you like, to be able to have a say in where those people perform, how they people perform, and to supervise their performance. So I cannot talk about impact. But I can talk about the number of trainings and the types of trainings that WHO has conducted and is still conducting. One of them is public health pre-deployment course, which is done at the global level. I'm talking about the field of emergencies, of course. The search training in EMRO. Currently, we are in the process of developing a training course, and CDC is very much part of that, in EMRO on public health pre-deployment training for emergencies. We are currently revising the curriculums with very well-known academic bodies, Johns Hopkins being one. And we hope that our first course will be in December, and then there is a plan to cover the regional countries with a number of courses between now and June 2016. We will, based on that, we will roster graduates from these courses, and God forbid if they are deployed to any emergencies, if emergencies take place and they are deployed, then maybe we can talk about how they perform based on the training that they are exposed to. Thank you.
If I can add also, I think you rightly mentioned yesterday about the FETB and in your presentation. And I think the FETB are playing a great role in investigation of these outbreaks. We're also very grateful to EMPHNET, which is also supporting us with this training. But still, we lack data to show the full impacts and statistics about this training. And we have around 20% trained last year with EMPHNET and rapid response teams in investigating outbreak of suspicious origin. But I think building capacities, helping countries in such disastrous situations which we cannot have any experts come to the country from outside. Thank you.
So I can speak only about humanitarian emergency response trainings that we've conducted, specifically with FETP, which has been at a sort of an ad hoc basis. It's based on country-specific requests. And we've only done a very few with FETP, primarily in Ethiopia, and then most recently with Iraq FETP due to the IDP crisis. Just talking to them as a follow-up, I don't have figures, but I can tell you that because of the need for this, we're trying to make this a formal curriculum for EIS and FETP so that they can respond, especially because there's a lot of places that the U.S. government can't access, and that we do rely on FETP and the local, staff to do these response efforts. So we've done a few, and we're hoping to make this more of a continued effort, and then have more information as we roll out this training next year.
So I am not sure if Dr. Faris is here, but we had very good example from Iraq as well. So that regional TOT that was trained rapid response already took the initiative and trained the whole country in Iraq, the whole governorates, to get them more familiar with rapid response outbreak investigation. I think this is one of another impact of such training, and the number, and the second one, how they act after such training. So we are following up with our, in collaboration with the FETV in Iraq, to see how they can utilize such a resources, train resources to help others and to train others. So it's became, since 2 years, I think, they have, this is around, in every TOT stopped in every governorate in Iraq where they can train other people. And this became very common in Iraq in the past 2 years. So I think this is another approach that we can consider. Yes, in terms of coordination, I think this is very important point, that as much as we can agree what we are doing, in the region and outside, it will be very value added, and we can, harmonize our all efforts to make sure that we are not duplicating each other, and we do not duplicate the work. Okay. We started at late 10 minutes, so we have another 10 minutes, yeah.
So thanks for the response, although it still doesn't actually totally address the question. But so let me just phrase it a little differently. What does success look like to you or any of the speakers on the panel when you say that you're doing rapid response training and rapid response training work? What does success look like to you? What would be what would you say that, oh yeah, our trainings are being very effective and we're very successful in the work?
Okay. You want to respond? I guess that's possible. Okay. As I mentioned, that our indicator for such successful training that our FTB residents go to the field and do the investigations, write the report, and produce something but as one of the officials at the Ministry of Health rightly said, that we doesn't have such a systematic methodology for investigating outbreaks until the FTB has been launched in Yemen. So we are proud with our teams. Still, we are needs more and more capacity building for our teams. But I think this is just incidental evidence or something you can say. Thank you.
So back to the success. Success, I think, how we make it more. I think the region will depend on, we need to depend on ourselves. And in the region, we have very, very good capacity. And we need to invest and to make sure that we are doing the work. So we see that countries in the region, it's very difficult to access these countries. So we need, to think about how we can create a new model, And second, I think, as Dr. Abdul Wahid and Dr. Kashif yesterday mentioned in his presentation about the curriculum. The curriculum is the fatal issue. We need sometimes to standardize the training materials, curriculums, and etc. Still, I think the golden rule for keeping these initiatives and other, efforts in the region to be continue to rely more on people from the region and to not wait until the last minute for international bodies to come to the region or to access to the countries that we know since long times that never they can access to. So we need to enhance our capacity in the region, and we need to enhance our in-country capacity as well.
I guess I wanted to invite you also to attend some sessions of some of these outbreak investigations today and tomorrow and after tomorrow about measles. This is a very recent in Sada city where the war has been started, about dengue outbreaks also in Lash where there is a lot of dengue cases. So we'll see some of the outputs from this training.
For me, success, and I think this is a bit philosophical, but this is my definition of success, is changing the system and changing the commitment of the decision makers to what we're doing. I think we do a lot of work on individual people's capacity building, on training people, but we are doing much less on making the system friendly and responsive. If we can make the system friendly and responsive, I think that would be our success. Thank you.
So I think they keep telling me that the time is over. It's a very nice session, very nice discussion. I would like to thank all of you, thank our speakers for today, our morning session. And I think we have announcement. Ms. Hiba wants to say something.
Thank you, Doctor. We have an important announcement for the poster presentations. We need you to drop off your posters at the break, please, so that we can make them ready by 2. For those who have poster presentation after tomorrow, they need to deliver them tomorrow morning. Thank you.
Thank you very much.